our patients with aligners, because there are still some doctors, most of. So, hello, welcome to my colleagues and friends from all over the world listening to this webinar about aligners, about treatment with aligners, and how mini implants can help us to make the aligner treatment more predictable, and how we maybe can treat in the future all our patients with aligners, because there are still some doctors, most of our patients with aligners, because there are still some doctors, most of the doctors think that aligners are only to correct some crowding, etc. But I personally think that aligners are the future, and I don't think that we will use many brackets and wires in 20, 30, 40 years. So, and I like to lecture about those cases where we need a bodily tooth movement and maybe have impacted teeth or orthopedic treatment purposes. And I'd like to show you how we can treat those cases with aligners as well by the help of small mini implants. I'm sitting now at the University of Düsseldorf, and so this is webinar number 2 about aligners and TADs, and last time I have invited you to visit us here as soon as the Corona crisis is over, and we have guests from all over the world. And if you want to come to our university for a couple of days, you are warmly invited to visit us here. It's a lovely city. So last time I talked primarily about distalization with our sliders and finishing with aligners. I talked about space closure with aligners, and we do see severe problems if we have spaces that should be closed with aligners. This is a slide I have shown at my first webinar. It was 3 weeks ago, and in most of the cases you see severe tipping. It might work out, but not in a predictable percentage. Okay, so in most of the cases you see severe tipping like you see in this case. In my last webinar I've shown the Bennett slider for distalization and the mesial slider for space closure or mesialization. And by using these devices we can get a bodily movement, not just crown tipping like we see mostly using aligners. And this is the big advantage of the combination of aligners and these sliders, that we get a bodily distalization or mesialization. And I've shown you many cases where we can unilateral distalize, bilateral distalize, unilateral close to spaces or bilaterally close to spaces. So I'm not going to repeat these cases. Today I'm going to show you a lot about orthopedic treatment, rapid maxillary expansion, because you cannot expand in a predictable manner with aligners. Okay, so these were the topics of the last lecture. And additionally to RME, orthopedic treatment, I will speak about other treatment goals that are not so easy to address with aligners only: molar intrusion, front intrusion and front extrusion, and how to align impacted teeth, how to design the mechanics in combination with aligners. So if you have followed my first webinar, you know that we in Düsseldorf, we love mini screws in the anterior palate. Is, from my point of view, by far the best insertion site with the highest success rate and not so many problems. This was one of our first clinical papers about mini screws in the anterior palate. You see, 13 years ago now, and now we have worldwide many followers. Yeah, For instance, one moon, he's using mini screws for expansion. I will speak about MAPE and expansion with mini screws during my talk. Again, this is the nice thing. We have a very high success rate. The screws in the anterior palate are much more reliable compared to screws in the infrazygomatic crest, buccal shelf, interradicular mini screws. So where to insert them? This is our favorite insertion site. It's called T-zone. We are nowadays mostly inserting paramedian. You can also insert median, but in young children the failure rate is a little bit too high because the suture area is not mature. And in adults, the suture area is very dense, so there's a high bone density. So my recommendation, go paramedian. The T-zone is very easy to identify. Just check out the area posterior from the rugae. Again, I have shown this in my last talk as well. We are now more or less only inserting paramedian because we found out that mini screws are a little bit easier to insert and they are more stable. You might see many cases with median mini screws, but this is because we have started 20 years ago with mini screws in the palate, so we have many cases with median screws. If you have mini screws in the palate, you need something to connect with your appliance. We started 20 years ago with a benefit system. Now there are many companies that have copied our ideas. And today I'd like to speak about the combination with aligners. We have hundreds of cases about the combination. We have many nice cases, but also problems. And I'd like to speak about the problems today as well. So we started 15 years ago with this combination in a two-phase protocol. What means two-phase protocol? Two-phase means we are first using only our mini implant-borne appliance for distalization, mesialization, expansion, alignment of impacted teeth, molar front intrusion, etc. As soon as these goals are achieved, we are taking an impression or doing a scan to finish the case with aligners. So the idea of this phase 1 is to modify our difficult case into an easy case and then do afterwards finish this easier case or easy case with aligners. But since maybe 10 years, we also have the one-phase protocol. That means we are simultaneously using aligners and our mini screw appliance. And I will show you many cases where we are combining these appliances simultaneously. This is a little bit faster, so I personally prefer this one-phase protocol, but everything in life has pros and cons. We have to think a little bit more about synchronization of aligners and our mini screw-borne appliance. So again, this was more or less topic in webinar 1. Today we will speak about the rapid maxillary expansion, molar intrusion, front intrusion, and alignment of impacted teeth. So let's start with expansion. How can we be successful when it comes to rapid maxillary expansion? And there are a couple of studies now published 3 years ago, 4 years ago in the ankle orthodontist. If you want to expand, it's more or less primarily tipping. Published last year in the ankle, expansion was achieved primarily again by tipping. And 3 years ago, another paper, systematic review, limited efficacy if it comes to arch expansion. So next to distalization and space closure, expansion seems to be a major problem. We can expand the crowns, But is it what we really want? In most of the cases, no. Because we want bodily movement, we want some nasal airway flow improvement. So the goal is to have less tipping. This is the reason why if you need more than maybe 1 or 1.5 millimeters of expansion in the upper arch, I strongly recommend to go for rapid maxillary expansion. And if you want to avoid dental side effects, add 2 TADs or maybe 4 TADs. We will speak about this later. And we have published this hybrid Hyrax appliance in 2008 for the first time, and again there are now many followers calling it MAPE, MSE, etc. We will speak about the differences a little bit later. You can also use this hybrid Hyrax for class 3 protraction. Okay, so you expand and protract the maxilla. Idea is to get less dental side effects. So we are using the hybrid Hyrax. We call this TADS first or bone first. Why do we call it bone first? We are first looking where is the best available bone, insert the mini screws in this area, and then design our mechanics. On the other side, One Moon and some others are using their appliance, which is prefabricated, inserting it, and maybe in this area is no bone. This is called appliance first. And from my point of view, it does make much more sense to check out where we do find much available bone and adapt our mechanics to this perfect insertion site. Okay, but of course on the right side it may be easier because you can just insert your appliance and screw in 4 TADs, but especially posterior lateral, there is no, in this area there is not much bone. If you have a look at cone beam CTs, maybe the bone height is 1 or 1.5 millimeters. Okay, and my recommendation was to stay in the T-zone. This is a T-zone. Okay, and screws inserted posterior lateral are not in the T-zone. Okay, so my recommendation, bone first and not appliance first. So let's have a look at some papers about the efficacy of RME. And this is what is really interesting for parents. There's a study from Stockholm from Farhan Bazargani, and he compared conventional expanders and hybrid Hyrax expanders, and he found out hybrid Hyrax induced more nasal airway improvement compared to conventional RME. And this is very interesting for the parents because they don't want to get mouth breathing child. They don't want their children to become apnea patients when they are older. Another paper just published a couple of days ago in the European journal. Hybrid Hyrax was associated with marginal greater probability for obstruction resolution. So again, you get more expansion of the nasal area of the airway flow through the nose. Okay, so it's not just to avoid tipping of the teeth, it's also a medical goal that we want to follow. Another very interesting paper, again published from this group from Sweden. They compared the conventional tooth-borne expander with the hybrid Hyrax regarding pain and discomfort. And this is a very interesting thing. Hybrid Hyrax had significantly lower concerning pain. Well, this sounds very interesting. Why? Because if you would ask me, and I'm not an expert if it comes to anything in orthodontics, I would say, of course, if you insert screws, this is more pain. But if it comes to expansion, there's less load on the teeth, and because there's less load on the teeth, there's less pain. So very interesting study. Less pain if you use 2 mini screws. Yeah, interesting study. So we are using the screws not just for expansion, but also for class 3 treatment. And this is a goal. We want to have a rigid coupling with the mini screws. And by using this rigid coupling with the mini screws, we can transfer the force to the bony structures, because if we are using our face mask for early class 3 treatment, we don't want the teeth to move forward, we want the maxilla to come forward. So very important. So avoid dental side effects, avoid mesial migration and extrusion of the molars. This is a major goal of using mini screws, avoid dental side effects. Okay? So how is the hybrid Hyrax conventionally used? We are inserting screws in the T-zone. It's not a big issue. It's not so difficult. Yeah? Take an impression. Nowadays we are using scanners, or we are digitally designing the appliances, but this is how we have done it for many years. The conventional approach. It's similar to using a tooth-borne expander, but we are using 2 mini screws. Again, the reason to avoid dental side effects. Yeah? Here you see the procedure after anesthesia. You can use, if the patient is afraid of a syringe, you can also use just topical anesthesia. Yeah? And I'm counting from 10 to 0, then the patient knows it's done in a couple of seconds. So it's not a big thing. Don't be afraid. Yeah? If you don't feel so comfortable with mini screws in the palate, you can use these insertion guides that are provided nowadays. Yeah? So this is again the conventional method, using silicone impression.
Yeah?
Taking an impression, and this is a hybrid Hyrax expander with 2 rings. And again, the goal is to do expansion with the hybrid Hyrax without tooth tipping, and do the finishing afterwards with aligners. Okay, so I will show you many cases with this, from my point of view, very smart combination. Yeah? So this is what it's all about. Some light curing, and this is it doesn't take more time compared to tooth-borne expander. So I like to show you some cases. I go over these slides very fast because this is not a class 3 lecture. This is more or less a aligner webinar. So expand and protract. Expand and protract. It's always the same. Yeah, we started 15 years ago with just expansion. Nowadays we are doing Aligner+ protocol according to Eric Liu. Yeah. Some studies about it. If you want to read more, these studies are also available on our website. Again, the goal is always to have no dental side effects in terms of tipping and in the sagittal dimension in terms of molar migration. This is a turbo for early class 3 treatment. Again, Aligner+, yeah, for 8 or 9 weeks. We even have some cases where we do this for a longer time. Do the difficult things with this appliance and finish the case afterwards with aligners. Okay, so we can improve with this hybrid Hyrax Aligner+ protocol. We have some cases where we have improved the width around about 6, 7, 8, 9, 10 millimeters. Yeah. So one of our first patients where we did Aligner+, 1 week of expansion, you can activate 2 or 3 times a day. Start with the face mask. In the second week we do compression, and 8 or 9 weeks depends on if you want to do expansion at the end or not. Yeah? After 9 months it's almost now a class 2 patient, which is nice. Yeah? Another patient with -8, so quite a class 3. Always have to check, of course, if there is a shift, a functional shift. If you have a functional shift, it's good for us. And this is a patient after the orthopedic treatment. Nice improvement of the skeletal structures. And now she turned 14, and then the growth is over. So, especially for those patients where we have a poor dental anchorage, yeah, the mini screws can really help us. So here we have a patient with a maxillary deficiency in the transversal dimension, but also in the sagittal dimension. Yeah? And additionally, the molars are migrated mesally. So we have more or less 3 problems. Yeah? We need to expand, but there are not enough teeth for dental anchorage. We need to protract the maxilla, but there are not enough teeth for dental anchorage. And we have to distalize the molars to get some more space. Okay, and for this purpose we have a nice appliance. It is called hybrid Hyrax distalizer. So it's a hybrid Hyrax, but we add 2 small distalization screws. Okay, this is how the distalization screws look like. You can order them from Forester Dentarum. This is not a rocket science, but we can achieve 3 different goals. Again, expansion, maxillary protraction, and after that, molar distalization. One of my favorite appliances, hybrid Hyrax distalizer. Okay, so we started with the difficult things: orthopedic treatment, rapid maxillary expansion, and maxillary protraction. And after that, we continued with the orthodontic treatment. Again, we needed space for the canines, so we started with distalization. The patient is activating this screw once a week, a quarter turn. Okay, so you see right here, the screw is closed, and this is after a couple of months, the screw is open. The patient is activating this at home. Again, 1 quarter turn per week. And now there's enough space for the canines. So with just 1 appliance, we have expanded, we have protracted, we have distalized. Now it's a class 2 patient, which is good because the mandible is going to grow in the next years. And now it's a very easy case that can be finished with aligners. So I love this combination. Do the difficult things with our mini implant born appliances and the easy things afterwards with aligners. Sometimes we leave the screws for a couple of months in place just for fun. It's like a piercing in the palate, but you should remove them after a couple of months, because in the next years it will submerge in the palate if there is some growth. So before and after, and again, patient was finished with aligners. Nice improvement of the profile, nice maxillary protraction. No dental side effect. These are our major goals. Yeah? Of course, we need a good compliance from our patients. We measured the wear time. This is a paper we have published about this. We used this small Theramon chip and integrated it into the frontal bar, primarily not to control our patients, but to motivate them. Okay? If you know somebody's measuring my efforts, kids are motivated a little bit more. Okay? So patient with a maxillary deficiency, 9 years, which is a good age from my point of view to start early class 3 treatment with a face mask. Again, the hybrid Hyrex distalizer. Expansion and maxillary protraction. Mostly we are taking 6 to 9 months for the active maxillary protraction phase, but I always recommend to not to throw the face mask away. We are using them as a retention device, maybe during the nighttime for the next months or even years, before and after maxillary protraction. And he was very compliant. He was wearing more than 10 hours per day, which is fine. So he had a lot of fun in our department. Yeah? So, but there are some patients who are not wearing the face mask enough time. And for those patients, we are offering a small mini plate. We learned this from Hugo de Klerk. What we are not using 2 bollard plates. We are just using 1 mental plate. Good thing about this mental plate, we can use it a little bit earlier. We don't have to wait for the canines. Of course, the flap is a little bit bigger, but this is not an issue for the patient or for the surgeon. So this is not a thing. The mental plate is very reliable. Failure rate is 0. Okay, so of course it's a surgery, but it is very reliable. Our first case using this mental plate after RME and after the active class 3 treatment phase. And again, now it's an easy case. You can finish with aligners, and this is what I'm talking about today. Again, for those patients who don't want a face mask, we are using this mental plate. Another patient, first address the difficult things with these mini screw borne appliances in the upper arch and the mental plate in the lower arch. So we need expansion, maxillary protraction and molar distalization. Okay, so we start with maxillary expansion. This is a hybrid Hyrex distalizer, not enough space for the canines. Maxillary protraction with the rubber bands from the molars to the mental plate hooks. We know this from Lorenzo Franchi and McNamara, Bacchetti and many others. The best age for early class 3 treatment seems to be around before puberty. So 8, 9, maximum 10. But sometimes the patients are coming later to our office, and we can of course send them away and say, okay, we cannot help you, we have to wait until your growth is finished. But some parents are pushing us and pleasing us. Could you please start? We want some improvement of his malocclusion of his face. So additionally, next to the class 3, he had an impacted canine in the second quadrant. Teeth in the second quadrant were migrated mesially. So what does he need? He needs expansion, maxillary protraction, and then unilateral distalization. Again, favorite appliance, hybrid Hyrex distalizer. These are the radiographs, and you see very easily the mesial migration in the second quadrant. Not enough space for the canine. So, in the lower arch, a mental plate. We have hundreds of these mental plates. Again, it's a surgery, but they are super reliable. Okay? A class 3 traction, we start with 200 grams. If you see it's fine, I'm rising the force up to 400 grams in the next months. Aligner+mini, very important. We want to loosen the mid-phase sutures. Aligner+mini, 1 week expansion, 2nd week compression, and so on. So he was super compliant. This is after 11 months. And now the difficult things orthopedically are achieved, are fixed. But now we have still not enough space for the canine, so we need distalization in the 2nd quadrant to get some space. So now the patient is activating this small distalization screw, and by using this small distalization screw we can unilaterally distalize and get some space. Again, just once a week, a quarter turn. Okay, you see, this is after 2 months of treatment. You see small space for the canine. After 6 months of distalization, you see now there is almost enough space for the canine, because there is also some space between the central and the lateral incisor. He's a class 3, so we didn't want to distalize too much. And the good thing, he can continue with the class 3 traction, okay? Because this appliance is rigid enough, you can orthopedically protract the maxilla, but orthodontically distalize the molars. I think this is a super smart appliance and really can help us for these kind of treatments. You see a nice bodily distalization in the 2nd quadrant. Now it was time in phase 2, because it's now a pretty easy case to finish the case with aligners. And I think this is the future. The patients don't want brackets and wires anymore. Most of the patients. There are still some patients asking for brackets, but most of the patients asked for aligners. So we did now the aligner finishing, left the 2 screws in place, and used the bender plate from the box, for skeletal retention, because we don't want a relapse in the transversal dimension, because we did expansion, we did Aligner+mini. Okay, so we have to take care about the transversal dimension, and aligners are not enough. We know this from these studies I have mentioned. The force for a transversal expansion, a bodily expansion, is or the resistance or the rigidity of the aligner is not high enough to withstand these transversal relapse tendency. Okay, we can continue class 3 traction. You can either use the lower dentition, or if you don't want reclination of the lower teeth, use the mental plate. Continue to use the mental plate. So we have to think, what do we want? So the last step in this patient was alignment of the impacted canine. So I removed the bender plate, inserted a new one with a small hook for alignment, non-compliance alignment of the canine. Of course you can attach a rubber band to the aligner, but of course you need another compliance step from the patient. You have intermittent forces because the patient is not wearing this rubber band all the time. So the advantage of this, we have a continuum force and to align these canines. Okay, so this is how it looks like now. Canine is almost in position, and the last step is the finishing with another set of aligners. I love to use this catch-cow method, but this is no rocket science. Probably you know this. If you have to extrude a lateral incisor typically, or canine, you can use this method. But have a look at the huge amount of improvement if it comes to the skeletal dimensions. Yeah? Minus 12.5, I would usually think this is too much for an early treatment. Usually I would think this is a surgery case. But again, check the functional shift. If you have a functional shift of 2 or 3 millimeters, this can help you. And then the real class 3 is a little bit less. So I love this multi-purpose use. Okay, use the screws for many purposes, and using mini screws with exchangeable abutments, you can do that. If you use a MAPA expander, you can just use it for expansion. If you use mini screws with exchangeable abutments, you can adapt many mechanics on the same mini implants. So we have just 2 mini implants. We used it first for the hybrid Hyrax distalizer. So RME and class 3 traction, distalization in the second quadrant, and we used the same screws afterwards. First for the bender plate for skeletal retention, after that for the alignment of the impacted canine in the second quadrant. Multi-purpose use. Maybe you know these Swiss knives, which have a multi-purpose use ability as well. Another patient who is primarily too old, 13, but the patients were really pushing me. Our daughter is not happy with her facial profile. The patients know that the face is not beautiful, and they're pushing me, please, please, please do something to improve her profile. No functional shift. You see a severe maxillary deficiency in the transversal and sagittal dimension. Width appraisal minus 9.7. Hybrid Hyrax with class 3 hooks in place. Start with expansion. Do aldramic, especially in those patients who are a little bit too old. I strongly recommend aldramic, but we see this clinically, that especially in those patients it is crucial. Why? The sutures are not so flexible anymore compared to young patients. Okay, so we have to loosen these sutures, these mid-face sutures, to get some skeletal effects. Okay, so this was a small modification of the mental plate. We call this T mental plate. We are not using this anymore because we had some failures. But in this patient, everything was fine. We started with aldramic, class 3 traction. Again, you can apply a higher force. I usually start with 200 grams, then after a couple of months I use 400 grams. And you can play with a line of force if you have, for instance, a risk of an open bite. This is why I have added these hooks in this patient. After 10 months of treatment, he was super compliant. Immense improvement of her skeletal structures. The mandible, the maxilla came forward a lot during this active class 3 traction period. Her mid-face was protracted and she was looking much better. And again, it's always the same. Do the difficult things with mini implant borne appliances, and afterwards it's an easy case if you have some compliance by your patient, of course. And now it's a typical easy class 1 patient. Just have to do some alignment. Of course, you can still use the mental plate if you want to avoid distalization of the lower teeth. And now she is in finishing, and it's a very easy case. This case is not finished yet because this patient is living in Dubai and she cannot travel to Düsseldorf at this stage due to Corona. But it's an easy case. So to sum up, if we have a class 3 treatment goal, we are always using the hyperthyrex. Why? We want to avoid dental side effects. We are using these class 3 hooks for class 3 traction, and we have high intermittent forces. So this is a reason why in class 3 patients we are still using mini screws and teeth as anchors. On the other side, if you just want to go for expansion, you might use just mini screws, 2 or 4, some are even using 6. So very important for class 3, we are still using teeth and mini screws. For just expansion, you may use just mini screws. And I'm happy to show you some cases in how to design the appliance and how to where to insert the mini implants. So first, let's start easy with just 2 mini screws, and this is possible in children, maybe up to 14, 15, something like this. And in patients, in adult patients where you have done SAPI. Okay, so 2 screws are enough for young children and patients after surgery. So I like to introduce you to this BMX expander because I really love it. Because it's super simple, because we don't have to take an impression, we don't have to do a scan. This expander is pre-fabricated, so we don't need a laboratory at all. So you insert 2 screws, either freehand or using insertion guides. And after inserting of these mini screws, you measure the distance between the 2 mini screws. We have 3 different expanders. These expanders are 6, 8 and 9 millimeters. So you measure the distance between the middle of the screw, and maybe this is 7 millimeter. Then you choose an expander with 6 millimeter between these 2 dots and activate the screw for 1 millimeter. Okay, so it's very easy and you can adapt this chair side. Again, there are 3 different expanders available, 6, 8 and 10 millimeters, and you can adapt it directly chair side. And it really works. I've done numerous cases now. So this is after fitting of this BMX expander. This is after expansion, and you see a nice trema. So in young children, 2 screws are fine. You see this expansion, and it's a bodily expansion. No tipping of the teeth. This will be published in the AJO in a summer issue. So from my point of view, nice strategy. And leave this expander now in place during aligner finishing as a skeletal retention, as a skeletal retainer. Okay, do the scan for the finishing. Of course, you can use also, if you want to remove this BMX, you can use a banner plate as a skeletal retainer. Maybe it's a little bit more comfortable for the patient, but we need something in place as skeletal retention. Very important. Okay, so this is now the finishing phase, and this is the patient at the end of the treatment. It just took 12 months. Okay, 1 month for expansion. Interesting, if you're using just a mini implant-borne expander, we don't have to do it fast. So rapid maxillary expansion is called rapid maxillary expansion because we used to use teeth as anchors. We needed to do this fast because we didn't want the teeth to move. But as soon as we are using mini screws, we can do a slow expansion. Okay, so we don't have to be quick anymore. So rapid maxillary expansion, I think, has to be redefined to maxillary expansion or slow maxillary expansion if we are using mini screws. Very important, and the future will show how slow we should expand. As soon as the patients are a little bit older, maybe 15, 16, adolescents, especially male, 2 screws are not good enough anymore. We need 4 screws or 2 screws and molars. Okay, in the future we need some studies. We need some threshold ages and recommendations, but we will see in the next 10 to 15 years according to future studies. So if you want to insert in between teeth, I recommend to use these insertion guides. This is a paper that will be published in the JCO this year. I've done this with my friends from Italy and the Easy Driver system. And 2 insertion guides were manufactured in the CAD/CAM technology on a cone beam CT basis. Because I'm a little bit afraid here to do this freestyle. In the anterior palate you can easily insert. So right here it's not an issue to insert, but as soon as you are in between the roots, I'm a little bit afraid to damage a root. Okay, so this is we call this quad hyrax or quad expander, and this works out fine. Another patient, adult patient, where we used the quad expander, 37 years. Would you go primarily for SAPE, or would you try to go for expansion without surgery? Of course, we have to discuss this with our patients. So she's a class 2 patient with maxillary deficiency. We see this very frequently. And if you just go for tipping of the upper teeth, you will see a relapse in the next 5-10 years for sure. So we need a bodily expansion to get to avoid the relapse. So primary goal was expansion in the upper arch and MEC-FEC surgery. But after successful expansion using this quad expander, sometimes we are using mini screws in the suture distally. But nearby the suture there is enough bone. But if you go here, like the MAPE guys do, there is almost no bone. So if you want to go posterior, my recommendation, stay nearby the suture. You see this right here. So anteriorly there is always enough bone, but posteriorly there is bone only in the middle. You see the bone structures here, and in this area the bone, the MAPE area, it is just 1 millimeter. This doesn't help you a lot. Okay, so the quad expander, and you see she's 37 and the suture opened. We do have especially male patients where the suture does not open, but you can try at least. We have many successful suture openings in adults using this kind of mechanics. So after 2 weeks of expansion, we can do slow expansion. We finish the case with aligners, and this is now an easy case. Again, we just need some alignments, and then we plan MEC-FEC surgery. Unfortunately, she refused MEC-FEC surgery, and we tried a little bit with class 2 elastics. But of course, she was severe class 2. So at the end, this is how it should like. she had a Sunday bite, yeah? But the profile didn't improve a lot because it was just a Sunday bite. Yeah? But this is how it looks like if she is biting in a class 1 occlusion. So again, first expansion with our quad expander. This is a difficult treatment. Afterwards, finishing with aligners. It's always the same. So I've shown you the bone first appliances. Mostly we are using the hybrid Hyrex, especially in class 3 patients. I personally love this hybrid Hyrex distalizer. You can use 2 screws or 4 screws, depends a little bit on the age. Yeah? But again, our focus is on bone first. Insert the mini screws in the best available bone. Yeah? And don't be limited to the prefabricated appliances. You won't be successful in many cases, in all of your cases, because there is not much bone. So in Düsseldorf we call the bone first, attach first expansion using mini implants. So in this case we just wanted unilateral expansion or unilateral movement in the first quadrant because we had a nice occlusion in the second and third quadrant. Yeah, so this is a little bit a nice smart mechanics. Use 2 mini screws. This is a bender plate with a flexible 0.8 wire. You can bend this chair side if you are good in bending, just to get some unilateral force for expansion. Combination with aligners, yeah, activated this, that you get force again just on one side. Very important. This is after successful correction of the crossbite. So next topic after RME is molar intrusion, because molar intrusion is sometimes very difficult, especially if it comes to over-erupted molars. We call this appliance mousetrap because it looks a little bit like a mousetrap. So we are not using screws buccally, we are not using screws in the infrazygomatic crest because they all have their disadvantages. We do love mini screws in the pelvic because they have the highest reliability. But then of course you need a wire, a little bit a framework. Yeah? So we started with the mousetrap with the TPA. TPA was inserted to avoid tipping of the teeth. And then we are adding this intrusion lever arm. So the mechanics is not it's not rocket science. It's not so difficult to insert this appliance. And then the wire is bent down, attached to the molar, and the force should be around about 100 grams per molar you want to intrude. Okay? So again, this is how it looks like. We have a TPA and we have a lever arm. This case was treated, I think, 15 years ago, so we used median mini screws. I think nowadays I would use par median mini screws. It takes a little bit time to intrude the molar. In the first 2-3 months you don't see much because a lot of bone has to be remodeled. But this is a situation after 7 months and you see a successful intrusion of maybe around about 3 millimeters. Another patient, we have many cases like this because we have many dentists referring this to our department because we are communicating to our referring doctors that we can do this. So you can communicate with your referring dentists as well, and you might get more and more patients. Okay, so not enough space for the lower dental implant. So the doctor asked us to intrude the molar, so you can do this not just with first molars but also with second molars. This is a mousetrap implant in place after a couple of months, and now the implantologist is super happy that he can insert a dental implant in the fourth quadrant. Mousetrap. Okay, you might use something like this vacuum stent if the patient has to adapt with the tongue to this appliance. So we did this in this patient, and this patient was super happy that there were no edges and wires, etc. So just a vacuum stent. Another patient over-erupted second molars, missing second molars in the lower arch, the mousetrap. In combination with aligners, again, it's always the same. Do the difficult things with the mini implant-borne appliances and the easy things with aligners. This is after intrusion of the second molars and at the end of the treatment after combination of mousetrap and aligners. Another patient. We did this in this situation with a two-phase treatment. First, molar intrusion, and after that, a finishing with aligners. Okay, so by the way, I just received some questions, and we will discuss these questions at the end. So again, this is before and after intrusion. You always have to check if the molar has enough space. Yeah, so sometimes we have to do some stripping. Very important. Yeah, if the molar is locked in between the two adjacent teeth, you cannot intrude the molar. Okay. So after intrusion, finishing with aligners. Again, this is what it's all about today. Combination of aligners and mini implant-borne appliances for difficult cases. So this was a mousetrap with a TPA, and now we tried something different. We call this mini mousetrap, and the difference between the mousetrap and the mini mousetrap is that we are designing the mechanics without a TPA due to comfort reasons. Okay, so we are using the bender plate with a 0.8 wire in place. If you're good in banding, you can adapt this chair side without taking an impression. However, I recommend to take an impression or do a scan and adapt it on a plaster model or printed resin model. Okay, so this is the design of the mini mousetrap. And we have no TPA, so everything in life has pros and cons. Of course, this is a little bit smarter appliance because it's less bulky, but we have to check, of course, if the arms are properly activated. Okay, because in the buccal, oral buccal dimension, there might be some movements you don't want to achieve. Yeah, so please check the proper activation. In this situation, it worked out very nicely. So this is before and after molar intrusion. Usually takes 5 to 8 months for 2 to 3 millimeters. Just to give you a rule of thumb how long it takes. Okay, after molar intrusion, again in the first 2 or 3 months you don't see much, so you have to be patient. Another patient over-erupted 1.7, mini mousetrap in place, 6 months for molar intrusion, around about 2.5 or 3 millimeters. So it's always the same. And again, you can combine it easily afterwards with aligners. Another patient. In this patient we had over-erupted bicuspids in the second quadrant. And this is typically, they had no antagonists. Okay, so over-eruption of these bicuspids due to missing bicuspids in the third quadrant. And like many patients, he asked for Invisalign. And it's not so easy to intrude these two bicuspids with just aligners. So additionally, we have this small bender plate with an 0.8 wire, and we can attach elastics or rubber bands for intrusion. This is after successful intrusion of the bicuspids in the second quadrant. Took around about 6 to 7 months. Before on the left side and after on the right side. And this is during the aligner treatment, and he's using class 2 elastics on the left side as well. So next step was transplantation of the wisdom tooth and the second quadrant in this area. And this is now the stage of the treatment. We are waiting until the transplanted wisdom tooth is in place, and we can continue with the aligner treatment. So, next topic is front intrusion, which is also not so easy with just aligners. So this is the only situation where I personally am inserting mini screws buccally. Mostly we are using the anterior palate, but if you want to do incisor intrusion, I'm adding in some cases buccal mini screws. Depends on if there is enough space in between the roots. So this patient was not happy with her super erupted incisors. We had a tendency of a gummy smile, and she wanted intrusion and retraction of her incisors. Okay, so treatment goal, intrusion of upper incisors and retraction. So to get a force palatally and buccally, which is the optimum from my point of view, because we wanted not just intrusion, but also retraction. Okay, so this is a treatment we have done in the last years. Since a couple of years we are doing everything using CAD/CAM techniques. So we are scanning, we are printing every appliance, we are not bending them anymore. Just to show you how this works, we are using our scanner, and so for digitization we have now a mesh of the upper arch, and then the next step is to design the mechanics. In this situation it was not a very difficult design. We just have designed this. It's maybe for you to start. If you like to design your mechanics, there are a couple of softwares that are available. So this is primarily a bender plate made in a CAD/CAM technique with two small hooks. So after printing it looks like this. It has to be polished, of course, afterwards. And then you can check the fitting on the model, on the printed model. And this is how it is fixed. Internally, sometimes I'm using a floss, because this is also a problem or a risk using these small expanders like the BMX, that the patients are swallowing it. So strong recommendation, use floss just to get sure that the patient is not swallowing these appliances if you want to install it. I think this is very important. We want to help the patients. We don't want to You don't want them to end up in the hospital due to severe emergency situations. So, 2 mini screws buccally. Again, we want to force palatally and buccally for intrusion and retraction. So the patient is using these rubber bands from the buccal mini screws to the self-made band plate with 2 small hooks. This is the treatment. During the treatment we see some nice intrusion of the upper teeth and retraction from left to right, closing the spaces, etc. And the patient is now happy with her situation. Another, from my point of view, very difficult patient, especially if you want to treat them with aligners. And more patients do want aligners, are coming into our office and are asking for aligners. And you cannot say, this is not, you're not an aligner case. Then the patient is going to another orthodontist. Okay, or even worse, going to a dentist who has not the experience treating patients orthodontically. So I think the future are aligners, from my point of view. So we have a severe deep bite, tilted occlusal plane, and in this case we need unilateral intrusion. Especially in the second quadrant. So again, this is the only situation where I'm still using buccal mini screws. This is the treatment plan. By the way, probably you know, correcting a deep bite is more difficult with aligners compared to fixed appliances. So you need attachments on the lower bicuspids, very important. We learned this in the last decade. And to get this unilateral intrusion of front teeth in the second quadrant, I have added a mini screw. I'm mostly using the dimension 1.6 by 8. Applying elastics, you have to cut make 2 cuts palatally that the patient can attach it to the aligner, and this is how the patient is applying these rubber bands. So again, we had the tilted occlusal plane. So in the second quadrant I used this intrusion elastic. In the first and fourth quadrant I used class 2 elastics to get some correction of these tilted plane. And he was wearing the elastics properly, so we're getting out of the deep bite very nicely, as you can see right here. And we had a nice correction of this tilted plane by using this unilateral mini screw. This is a patient at the end of the treatment. He was wearing class 2 elastics, especially on the right side, and 1 mini screw rubber band on the left side at the end of this treatment, before and after. So sometimes we have problems with incisors. Aligner experts are calling this watermelon seed phenomenon. What does this mean? The lateral incisor is squeezed in an infra position. You see this right here in the aligner. And of course, you can now ask the patient to wear up and down the catch-cow elastics. But some patients are not wearing these aligners enough and you struggle with the patient, you fight, you motivate. So as an alternative, I like to show you a fixed appliance for extrusion of lateral incisors in combination with aligners. Okay, using buccal mini screws. So this is how it looks like. Very important, if you want to extrude an incisor, you always have to check, is there enough space? So maybe you have to use your polishing strip and check the available space. So this is a 16 by 22 stainless steel wire. We have an open spring, and if this open spring works, the lateral incisor is extruded 24 hours, 7 days a week, without any compliance that is needed from the patient. Okay, so this is after a couple of months. Extrusion is much faster compared to intrusion. As soon as you have enough extrusion, you can block it by using this resin. Okay, so this is a little bit like a retainer. Okay, so use some resin to block this, that the incisor is not relapsing. This is after removal of the mini screw. She was so happy with the screw in the first quadrant that we have done the same in the second quadrant. Okay, extrusion of her lateral incisors before and after without any catch cow elastics. Okay, so this is maybe a nice smart option for the patients who are not wearing catch cow elastics before and after. So, last topic for today is how to align impacted teeth and how to design the mechanics, because sometimes I see screws that are inserted right next to the canine that should be aligned. And of course, this mechanics is nonsense, it's stupid, because you always have to think about the line of force. Mostly we want to extrude the canine, so we have to plan the mechanics properly and don't just use a mini screw without a good line of force planning. If it comes to alignment of impacted teeth, we can always choose between direct and indirect anchorage. This is not my primary topic of today. We have many courses about this. So we have both direct anchorage cases, indirect anchorage cases. So both has pros and cons. On the left side, the mechanics is a little bit smaller, but one mini screw, especially in young patients, has a little bit higher failure rate. So we mostly use indirect anchorage, coupling with the molars. And this screw is used to avoid tipping of the molars. Okay, on the right side, we wanted to extrude a central incisor. So I'd like to show you some cases. Again, combination with aligners is the goal, is always possible. In this case, we had a second molar tipped mesially, impacted. Very important, the line of force must be not just extrusive, because then you might get some trouble with the first molar. The line of force must be extrusive and to the distal. And of course, this is not so easy, but it's much easier if you have a good lever arm. And this is the reason why we are inserting in the anterior palate, which is the best area, and then we are designing the appliance according to the line of force that is needed. So in this case, we needed extrusive force and distal force to get the second molar away from the first molar. We are using this banner plate with an 0.8 stainless steel wire. This is after alignment. And my recommendation, don't unscrew the mini implants. Leave them in place. Now you can use them for a second purpose. Maybe distalization to get some space for the canine, etc. Another patient, I think this is a very interesting but also very difficult patient. So I take a couple of minutes for this case. We had an impacted canine in the second quadrant. Looks like this, and unfortunately the canine has resorbed the central incisor in the second quadrant. So we have to think about the treatment plan very properly. I think, what would you do? Try to get some space for the canine and try to get the canine in its normal position. As an alternative, extract the central incisor that was resorbed and put the canine in the position of the central incisor. And this is a decision we have made, because we had a look at the cone beam CT and we saw the central incisor has a severe resorption. So the treatment goal was to move the canine in the position of the central incisor and additionally do space closure by moving 4, 5, 6, 7, 1 teeth forward, that 4 will be in the position of the canine, and etc. Okay, so treatment plan: extraction of the central incisor, substitution with the canine, mesialization in the second quadrant. The first bicuspid comes into the position of the canine. And of course, this patient asked for Invisalign. So what do you do? Send the patient back and say to the patient, no, this is not possible. You are stupid. Please go to somebody else. Maybe this is not the best solution. So you have to think about this case and try maybe something you have not done before. So again, treatment plan was alignment of the canine, move the canine into the position of the central incisor. So this is the design of the first appliance. Mesial slider for mesialization in the second quadrant. And we have added a temporary pontic because it's a young girl. She don't want to go to school. This was 2 years ago or 3 years ago when the schools were still open, with one missing tooth. So if you want to design your mechanic smart, always add the things that are needed. In this case, we have a mesial slider with a temporary pontic in place. And there's another nice gadget. I have asked our technician, please, I need a small wire to get the correct line of force. And he added this small hole. So now I was able to pull the canine away from the lateral incisor, because central incisor was damaged. I didn't want to damage the lateral incisor at all. So first important treatment goal was to move the central incisor away from the lateral incisor. Okay, so this is why the line of force is always very important. Listen to Ravi Nanda's lectures and nowadays webinars. This is what he is always talking about. Okay, so pull the canine median And I think this is a smart design of the mesial slider with this podic in place, with this small wire and the small hole. Yeah. So the canine moved now median, came down more and more. Now I changed the line of force. You see there was the first hole in this area median. In this area I have made a second hole because it's driving a car. Yeah, you have to go maybe first right, then left. It was now away from the lateral incisor, but now it was moving into the direction of the other central incisor. So I have to switch the line of force and to pull the canine now a little bit more to the distal. It was moving down, and again, in combination with aligners. You can use aligners at the same time. Yeah. This is now the further procedure, alignment, extrusion of the canine, and the final finishing with another set of aligners. And this is the final outcome of the patient. Yeah? And she's now happy. She's loves to smile again. Yeah? So I think an interesting patient that is not super normal. At the end of the lecture, I like to speak about the digital future. I spoke a little bit about this topic at the end of my last talk. And as mentioned before, we are not bending our appliances anymore. Nowadays, we are planning them digitally. Yeah? And we have two strategies that help us a lot. We are using insertion guides, and we are CAD/CAM designing and printing the mini implant-borne mechanics nowadays. We learned a lot from Simon Graf, my friend from Switzerland. This was the first paper we have published about a rapid maxillary expander, CAD/CAM made rapid maxillary expander. Depends on the scanner you are using. You need to use these scan caps or scan bodies. We are using the 3-shape scanner. We don't have to use these scan bodies, okay? Because it's a metal surface, and metal surfaces have the tendency to reflect the scanner, and some scanners don't have the ability to scan metal surfaces. So it depends a little bit on your scanner if you really need these scan bodies. We don't need them. And then you can design your appliance. There are many softwares out there. For instance, from 3Shape, the Auto Appliance Designer. This is a freeware called Blender, but it takes a lot of time to get familiar with it. So I don't recommend to do this, but if you're a tech fan, and like to take your time, this is maybe okay. And you can design your wires as rigid as needed. This is a big advantage of these mechanics. For expanders, for instance, we can design these wires super rigid, yeah, because we don't want them to bend. Yeah? So very high rigidity. And another advantage in Gadget are these insertion guides, and they help us a lot to find the perfect position. And maybe it's also a good idea for you if you want to start with palatal mini implants, and I can really encourage you to do so because they're helping us in so many situations. And I think the combination with aligners is one of the future roads we are walking in orthodontics from my point of view. So if you want to start with these mini implant-borne mechanics in the palate, and you're not so super familiar with the insertion of screws in the pallet, try to start with these insertion guides. They give you a lot of confidence because the insertion site is planned before. Yeah, you can plan it, a technician can plan it, then you approve it, like Aligner treatment, for instance. And another big advantage is that you can insert the mini screws and the appliance in just one appointment. Yeah? So you don't need an impression or a scan after mini implant insertion. Or if you want to send the patient to your surgeon for mini screw insertion, he can use the insertion guide. There are no communication problems because it's very crystal clear where the mini implants must be and are going to be inserted. And in the morning, maybe the patient is going to the surgeon for mini implant insertion, and in the afternoon, you in your orthodontic office are fixing the appliance. Okay, so I think these are the future treatment procedures on an everyday basis. We started the university spin-off service, and we are combining these CAD/CAM insertion guides with the CAD/CAM appliances, and you can upload your maxilla. Please don't forget to scan the palette, and you will get an insertion guide and a CAD/CAM appliance. I can strongly recommend to try this, to check this out. The website is tagman.de. The service is in English, and it's providing these appliances and guides worldwide. So in Brazil, in Australia, in the United States, you can use this service worldwide. Yeah? I think this is the future. You order like you order aligners. Yeah? Just upload your STL files, you get a proposal for the mechanics, for the insertion guide, you approve, and then everything will be manufactured. For instance, a hybrid Hyrax distalizer, which I really like, especially in the combination with aligners. Yeah? So today I have shown you a couple of different difficult cases, how to combine aligners with those mechanics. In the first webinar, I spoke about space closure and distalization. If you want to learn about more about pads, TADs, I recommend to go to our website. This is a university website. Just scan the QR code. And there are many papers for free download. So there are now a couple of questions. Maybe we can discuss these questions. Can you give us a maximum age limit for MAPE? Well, there's no maximum age limit. I have patients with 40, 50 where I was successful with expansion. But of course, the older the patients are, the higher the risk is that the suture is not opening. Of course, you can do a cone beam CT in advance. There's a nice paper about the classification of the suture, and there are a couple of stages, and you can have a look how big the chance is that you can open the suture. But I know many friends and colleagues that this classification is not always super accurate. So sometimes the proposal is correct and sometimes it's not. So next question, what is the activation regime for maxillary expansion? And can you do the widening and distalization at once? Very good question. So for activation in the transverse dimension, I mentioned this, we are mostly using the hybrid Hyrax and the Alt-Ramec. We are activating 2 or 3 times a day, Alt-Ramec, because we have to do some speed. But if you are not doing class 3 treatment, if you are not doing Aligner+mini, you can do a slow expansion. So I do have patients where that I asked to activate the expansion screw just once a day or even once a week. So in the future, I think we can do a slow expansion. On the other hand, the mini screws have the highest stability at the very beginning. So from this point of view, we should use them as early as possible. So in the future, we will see and give you more profound recommendations about this. Okay? So next question, can you do the widening and distalization at once? No, you can, but this is not smart. My recommendation, do expansion. Wait for at least 3 months, because if you do expansion with a hybrid Hyrax, you are moving the teeth a little bit into the cortical buccal bone, yeah? And then they are blocked for distalization, so wait until they are not pushed buccally into the bone and do the distalization a couple of months later. Very good question. Next question, do you routinely suggest your patients the mental plate instead of the face mask? No, I mostly recommend the face mask. But some parents say, oh, my child is not wearing this from the very beginning. Then you can say, okay, we can directly go to the mental plate. Option number 2, you can start with a face mask, see how good the compliance is. If the compliance is good, perfect. If the patient is wearing the face mask not enough, you can vote or you can propose the mental plate. Third point we have to consider, we know this from Hugo de Klerk's papers, using mental plate or bollard plates, we see less vertical bite opening compared to a face mask. So if you have a patient where you see a high risk of opening of the bite using a face mask, you could recommend a mental plate from the very beginning because of the vertical structures. We have published a paper about this as well in the Progress in Orthodontics. I can send it to you if you want to. So next question, how can you be sure that those who do not cooperate with the face mask will wear the elastics for the mental plate? Very good question. We could not get sure, of course, but if patient and the parents are going to the surgeon for the mental plate, they are somehow motivated. Yeah. Additionally, there are some fixed springs you can use instead of rubber bands. What's the name of them? I think about this, maybe I find out. So you can use these fixed springs, yeah, instead of rubber bands if you see there is not enough compliance. Risk of these springs, they're sometimes breaking, so you have some emergency appointments. Okay. Next question. Do you routinely suggest to your patients the mental plate instead of the face mask? Is there high acceptance for the surgical procedure? Is there high acceptance for the surgical procedure? I think it is. If you show the patient some pictures, these are the pros, these are the cons. Not all of the parents want this plate, but the acceptance, I would say, is high. Of course, there's an additional cost. Yeah, this is another factor. Is there a limit for intrusion of molars? No, I have intruded molars about 6-7 millimeters. Is there a theory that you can't intrude in basal bone? No, bone is no metal, so you can move teeth if you have bone. You can even, we spoke about this at the last webinar, you can mesialize in closed spaces if you have a deep sinus, where many colleagues say this is not possible. Did you ever perform orthodontic extraction on aligners of anterior teeth before implant placement. Did you ever perform orthodontic extraction on aligners of anterior teeth before implant placement? Actually, I don't understand this question. Okay, so at the end of my lecture, I like to invite you to Düsseldorf. Again, if the Corona crisis is hopefully over soon, you can visit us. We have a nice meeting in June, and I'm very much hoping every day that we can do this meeting in June. So hopefully major topics will be space closure and a combination of aligners and TADs, and I'm very much looking forward to some of the best speakers that we have in the orthodontic scene. So we have Marco Rosa, Björn Ludwig, Kenji Ojima. He's a heavy aligner user, so I'm very much looking forward to this combination. Patricia Medland coming from Australia, and she's also in the States. Gina is coming from Athens. Susanna is from Düsseldorf. Prof. Drescher, he's head of our department, and Jörg Schwarz is also one of the aligner heroes. So it will be a very interesting meeting, and I'm praying and I'm hoping that we can do this this year. We have a nice video about this meeting. I'd like to show you this now at the end. So hopefully we can travel in June. So let's come to the take-home messages at the end of my lecture. Message number one, take-home is number one. I think the anterior palate is by far the best insertion site. We are using it for so many purposes. We see a couple of advantages: low failure rate, no risk of root damage. We can move the TADs as we want. They are not at the path of our moving teeth, and very smart is the combination with aligners for many purposes, as I was trying to show you in these two webinars. So we are using the mini implant bone mechanics for bodily movements, and the three applications that are mostly used in our university are, of course, distalization, space closure, and rapid maxillary expansion. The question arises, do we do this now in a one-phase or two-phase protocol? Again, what means two-phase protocol? We are first doing distalization, mesialization. As soon as this goal is achieved, we take a scan for aligners. Or do we use aligners and this appliance simultaneously? So both is possible, which is good. But everything in life, again, has pros and cons, and mostly the two-phase treatment is a little bit easier because we don't have to synchronize these two mechanics. On the other hand, if you're using them simultaneously, it's a little bit faster. So we distalize the molars, for instance, at the same time we are aligning the front teeth. Okay, so this is a little bit maybe more interesting for those doctors who want to be finished as soon as possible. Yeah. For R&E, we are always doing a two-phase treatment. That means we are first expanding. After expansion, we are doing a scan for the aligners. So for class 3 therapy, we are always using the hybrid Hyrex. And if only expansion is needed, we are using pure bone expanders. Of course, in some cases we have tooth-borne expanders, especially in those cases where the teeth are tipped mesially, because then we want some tooth movement, tooth tipping. Okay, but for those cases where we want to avoid dental tipping, we are adding 2 screws or 4 screws. Yeah? Very important is your communication with parents. And if you want to start next week with mini screws in the palate, again, I can just recommend this and encourage you. Try to avoid the words implant or bone screw, because the patients might be scared because of these words. So we are using mini implants, we are using temporary anchorage devices, we are using titanium pins, and so don't use bone screw or implant. So we think of these small TADs, super sophisticated, everything is fine, we do CAD/CAM design, but if you choose the wrong words, patients might think that you're using big screws, implants, nails, whatever. So communication with the parent is very important. So at the end, I'd like to thank you very much for your kind attendance, and you can contact me for questions on Instagram directly. We have a site, this is called Benefit Applications, where I am posting cases not from our clinic but from private offices, and we are discussing pros and cons of different appliances. So I strongly recommend to check this out. You see appliances for distalization, mesialization, untypical situations where we have a multi-purpose appliance, etc., etc. For the CAD/CAM and the digital future of these appliances, I recommend to check out the TADman site. Again, this is our University of Düsseldorf website. You find many papers. So at the end, thank you so much again for your attention. I hope to see you soon at a congress or meeting.